Some pulmonary embolisms are obvious. Others walk directly into pulmonary clinic appearing relatively stable until you notice unexplained hypoxemia, tachycardia, or shortness of breath that simply does not fit the rest of the clinical picture. One of the classic concepts we think about is Virchow's triad: venous stasis, endothelial injury, and hypercoagulability. Many outpatient pulmonary patients have risk factors that fit into one or more of these categories. When evaluating possible pulmonary embolism, I first look for unexplained exertional hypoxemia, acute dyspnea, pleuritic chest pain, or hemoptysis. Some patients present more subtly with fatigue, reduced exercise tolerance, or persistent tachycardia. I also pay close attention to the lower extremities. Unilateral edema, calf pain, tenderness, or even a positive Hohmann sign can raise concern for underlying DVT that may embolize into the pulmonary vasculature. While Hohmann's sign itself is not highly sensitive or specific, it still contributes to the overall clinical picture. Risk factor assessment is critical. I routinely ask about prior pulmonary embolism or DVT, recent surgery, prolonged immobilization, hospitalization, malignancy, estrogen therapy, obesity, pregnancy, smoking history, and chronic inflammatory conditions such as rheumatoid arthritis. COVID-19 is also important because it can create a significant hypercoagulable state and increase thrombotic risk. In pulmonary medicine, many patients already have impaired reserve. Individuals with interstitial lung disease, COPD, pulmonary hypertension, or obesity may clinically deteriorate faster when pulmonary embolism develops because they often have limited cardiopulmonary reserve at baseline. Family history matters as well. I often ask about inherited thrombophilias, such as factor V Leiden mutation or other clotting disorders. One of the most common laboratory discussions involves D-dimer testing. D-dimer can be very useful in lower-risk patients because a normal result may help exclude pulmonary embolism in the correct clinical setting. However, it becomes less specific with increasing age because baseline levels are frequently elevated in older populations, inflammatory states, infection, malignancy, and chronic disease. That is why clinical probability assessment remains extremely important. If suspicion remains elevated, imaging becomes critical. CTA chest is typically the primary imaging modality because it allows direct visualization of clot burden within the pulmonary arteries. However, not every patient is an ideal CTA candidate. Patients with advanced kidney disease or contrast allergy may instead undergo ventilation perfusion scanning, commonly referred to as a VQ scan. In outpatient pulmonary medicine, pulmonary embolism is sometimes discovered during workup for unexplained hypoxemia or dyspnea that initially seemed out of proportion to imaging or pulmonary function testing findings. Occasionally, pulmonary function testing may even appear relatively normal despite significant vascular disease. Once diagnosed, treatment typically involves anticoagulation. Some patients may only require about 3 months of therapy if the event was provoked by surgery or immobilization. Others with recurrent clotting events, active cancer, inherited thrombophilia, or unprovoked pulmonary embolism may require extended or lifelong anticoagulation. Depending on severity, some patients temporarily require supplemental oxygen until they return closer to baseline. Pulmonary rehabilitation may also help improve endurance and recovery following pulmonary embolism. In younger patients or those with recurrent or unexplained clotting events, hematology evaluation is often appropriate to investigate for underlying hypercoagulable disorders and guide long-term management. One of the biggest lessons in pulmonary medicine is that pulmonary embolism does not always announce itself dramatically. Sometimes the diagnosis comes from recognizing subtle physiologic clues and identifying when something simply does not fit the expected outpatient picture. Have you ever encountered a pulmonary embolism that presented subtly rather than dramatically? Let me know in the comments below. And as always, thank you for joining me here on the Pulmonary Perspective.